Good morning students. Today we are going to discuss the humerus bone. This is the longest bone of the upper limb. Now if we see the parts of this bone, it has upper end, it has shaft and it has lower end. In the upper end there is head, then there is neck, lesser tubercle, greater tubercle. In between the tubercle, bicipital groove is present or intertubercular groove is present. And this is the shaft which is rounded in the upper half and triangular in the lower half. And this is the lower end, in which you can see it has articular surface which is going to articulate with the radius and ulna, and it has non-articular component. Now these parts, the knowledge of these parts is important because the side determination of the bone is very important, and side determination can only be done if we know the different parts of the bone. Now this is the head of the humerus. For side determination, the head of the humerus should face medially upward, and lesser tubercle should face anteriorly and greater tubercle should face laterally. And for the anatomical position, what is required is this head which is directing medially and upward, it should be slightly backwardly rotated. So the rotation is little bit on the back side. So the direction of the head it is directed medially, it is directed upward and backward. And with this rotation, definitely this medial epicondyle, which is larger one, it is slightly rotated backward. So this is the anatomical position of the humerus, and it is of which side? It is of left side. Now coming to the detailed description of the different part, first we will discuss the upper part. In upper part there is head. Then it is next to it is a narrow neck which is known as the anatomical neck. Then it is the lesser tubercle, and this is the greater tubercle, and in between this it is the intertubercular sulcus or bicipital groove. Now this head portion, which is forming the 1/3 portion of a sphere, it is covered by the hyaline cartilage, and it is going to articulate with the glenoid cavity of the scapula to form the shoulder joint. Now next to it is the anatomical neck. To this anatomical neck, the capsular ligament of the shoulder joint is attached, but this capsular ligament is deficient in the upper portion of this bicipital groove, or that groove which is present between the two tubercles. Why it is absent over here? Because it has to give weight to the tendon of long head of the bicep. And second important feature regarding the capsular ligament is when it is just coming and covering the margin of the head of the humerus, it is coming 2 cm or extending 2 cm on the medial side of this, that is below the head of the humerus, that is on the shaft it is extending. So the epiphyseal line is coming, or it is covered by this capsular ligament in this region. Now coming to the lesser tubercle. Now this is the lesser tubercle which is giving insertion to the subscapularis muscle, and transverse humeral ligament is attached to it. Now this is the greater tubercle. If we see the greater tubercle on the posterior side, we can see the 3 facets, that is superior, middle and inferior facet. To the superior facet, the supraspinatus muscle is attached or inserted. Middle one is giving insertion to the infraspinatus, and the lower one is giving insertion to the teres minor. Now this bicipital groove or intertubercular groove, which is present in between these two tubercles, now it has 2 lips. It has medial lip, it has lateral lip, and it has a floor. Now this medial lip is giving insertion to the teres major muscle, and the lateral lip is giving insertion to the bilaminar tendon of the pectoralis major muscle, and floor is giving insertion to the latissimus dorsi. Now through this bicipital groove, the important structure which are passing are, that is tendon of the long head of the bicep, synovial sheath covering that muscle, that is a tendon of bicep, and third is ascending branch of the anterior circumflex humeral artery. Now next to this, it is followed by, next to it is lying this marked part is basically surgical neck of the humerus. Now this surgical neck is the commonest site of fracture for the humerus. And why it is called as surgical neck? Because axillary nerve is lying in relation to it, and 2 vessels, that is anterior and posterior circumflex humeral vessels, they just wind around this neck portion. If the fracture of this region is happening, definitely it may cause damage to this nerve, that is axillary nerve, as well as to the circumflex humeral vessels. Now coming to the shaft portion, as I have told you that upper part of the shaft is rounded and lower part of the shaft is triangular. Now this shaft has three borders, that is anterior border, it has medial border and it has lateral border. Now anterior border, if you see, that is, this is the bicipital groove. The anterior border is starting from the lateral lip of the bicipital groove, coming downward and running on the anterior side of the lower part of the humerus. So this is the anterior border. In the middle portion, this is forming the anterior margin of the deltoid tuberosity. Now medial border is just continuing, or it is the continuation of the medial lip of the bicipital groove running downward. In the center portion, here it is rough because there is the attachment of the coracobrachialis muscle. You can feel here, rough over here. Then coming downward, it is continuing with the medial supracondylar line. Now lateral border of the shaft of the humerus is basically, it is not traceable in the upper portion, but in the lower portion it is continuing with the lateral supracondylar line. What is important here is that this lateral border is crossed in the center portion by a groove which is known as radial groove or spiral groove. So this spiral groove would cut the lateral border in the middle portion, and it is not traceable, barely traceable in the upper portion. And in the lower part, you can see it is continuing with the lateral supracondylar line. Now the important structures which are related over here are, that is, lower portion of the this anterior surface, that is anterolateral and anteromedial surface. So three surfaces are there definitely, that is anteromedial surface, anterolateral surface and posterior surface between these three borders. Now this anteromedial surface and anterolateral in the lower part giving origin to the brachialis muscle. In the posterior portion, this is the posterior surface, you can see an oblique line. There is an oblique line which is giving origin to the lateral head of the tricep. In the lower portion, it is crossed by a groove. You can see here, there is a groove present on the posterior side. So this is known as radial groove or spiral groove, as I have told you. And this radial groove is occupied by radial nerve and profunda brachii vessel. And in the lower portion of the posterior surface, this one, it is giving origin to the medial head of the tricep. So here is the medial head of the tricep. This is a radial groove which is crossing it. You can feel here. So this is the radial groove which is just crossing this portion. You can see the radial groove over here. And above this, there is an oblique line which is just passing behind it, which is giving origin to the lateral head of the tricep. Now that is on the lateral side, if we see, here is the deltoid tuberosity. Here the insertion of the deltoid muscle is happening. So these are the structures which are present in the shaft portion. Now coming to the lower end. Lower end is articular as well as non-articular. Articular portion is the capitulum and trochlea. This is the trochlea, which is a pulley-shaped structure. And this trochlea is going to articulate with the ulna, and this capitulum is going to articulate with the head of the radius. So this is articular portion. And non-articular portion, it includes the medial and lateral epicondyle, two supracondylar ridges, that is medial and lateral supracondylar ridges. You can see here. This is the medial supracondylar ridge, this is the lateral supracondylar ridge, and three fossae. They come under the non-articular portion. That is, one fossa is above the trochlea, that is coronoid fossa. One is above the capitulum, that is radial fossa, and third fossa is lying on the posterior side, that is oligrenum fossa. So the articular portion is capitulum and trochlea. Non-articular is medial and lateral epicondyle, two supracondylar ridges and three fossae. Now in the flexed elbow, the head of the radius, it fixes in this radial fossa, and coronoid process of the ulna, it fixes in this coronoid process. In the extended elbow, the oligrenum process of the ulna, it fixes in this portion. Then what is important regarding the medial epicondyle is that this medial epicondyle is giving origin to the flexor muscles of the forearm, and on the posterior side it is in relation to the ulnar nerve. And out of these flexor muscles of the forearm, pronator teres has additional origin from the upper portion above that medial epicondyle, that is from the medial supracondylar ridge, that is pronator teres is arising. So it is getting origin from this medial supracondylar ridge just above the medial epicondyle. That is the additional region. Then on the lateral side, this lateral supracondylar ridge is giving origin to the extensor carpi radialis longus in the lower portion, and upper 2/3 portion of the lateral supracondylar ridge is giving origin to the brachioradialis. Otherwise, this lateral epicondyle is giving origin to the extensor muscles of the forearm. So lateral epicondyle is meant for giving the origin to the extensor muscles of the forearm. Medial epicondyle is giving the origin to the common flexors of the forearm. So this is regarding the lower end. Now, if we see this trochlear-like pulley-shaped structure, it has medial flange, it has lateral flange. Now this medial flange is 6 mm below than the lateral flange, and this downward projection of the medial flange is responsible for the carrying angle in extended and supinated forearm. Now, after the description of the humerus bone, what is important is the ossification. Ossification, this bone ossify from one primary and 8 secondary center. Primary center is for shaft, which appears by the age of 8th week of intrauterine life. For the upper end, there is one center for the humerus, one for the lesser tubercle, and one for the greater tubercle. Head center for the head, it appears by the age of 1 year, and for the lesser tubercle by the age of 2 years, and for the greater tubercle by the age of 5 years. And these three center, they fuses with each other by the age of 6 years. And this whole upper end fuses with the shaft by the age of 20 years. So this is the growing end of the bone. In the lower portion, medial epicondyle has an independent secondary center which appear by the age of 4 to 5 years and fuses with the shaft by the age of 20 years. And rest of the three center, that is one for the capitulum and lateral flange of the trochlea. This is one center. Another center is for medial flange, and third center is for lateral epicondyle. Now center for capitulum and lateral flange of the trochlea, it appear by the age of 1 year. For the medial flange, it appear by the age of 9 years, and for the lateral epicondyle, it appears by the age of 12 years. And these three center, they fuses with each other by the age of 14 years. And this whole portion is fusing with the shaft by the age of 16 years. So by seeing this ossification, we can say this is the growing end of the bone. And moreover, the nutrient foramen, which is present on the medial border, you can see here, it is directed downward. So the opposite to it is the growing end of the bone. So humerus has three important nerves which are related with it, which is important for you is, one is axillary nerve in the cervical neck, second is radial nerve in the radial groove or spiral groove. This is the spiral groove. Radial nerve is related along with profunda brachii vessels. And with the medial epicondyle, here is on the posterior side, ulnar nerve is related. So these important landmarks are for humerus. They are that you should know that, because if any fracture or any injury is happening to the bone at these level, definitely they are going to affect these three important nerves. Thank you.